if I
This
clicked on the
conference
right
will
link.
now be recorded.
So if I started the wrong one, sorry. I was just excited to get here for once.
That one is, that GoToMeeting is our Hemodialysis Academy account. So if you logged into that, you would have had access. But the link that got sent out, and it's the same link. But when I clicked on the calendar link, it just it took me to some bizarre place.
Okay, so I just want to make sure that so I did the same. I just clicked on the calendar link. Did everybody else do that? I just want to make sure that in case other people are trying to join, should I send out a follow-up email or no?
It should have happened because the ID is the same, but there was a space in it. So that 597, and then there was a space in between the 7 and the 1. Maybe that was it. And then I finally went in and just added that number as a join a meeting, and I think that worked. So I think there was a space got added to the calendar link.
Oh, okay. Okay, so let me see. You guys should be seeing the invite that we sent out. Hopefully, are you seeing my screen?
Yeah.
Yes.
Okay, so it looks like Sabrina's arrived, and I guess we'll just, Sabrina, if you can hear us already, Mary said she's having problems accessing it, but I don't know if you're in the office today and you can help her or no. I also don't know if you're muted. You are muted. Let's see. You might not have called in here. So, okay, so other than working through the technical issues, we have the case that Dr. Foster has had multiple kidney biopsies for, and then also it kind of is a similar situation with another case that I have not yet finalized, but it's an OSU case that has had a repeat biopsy post immunosuppression. And so based on the fact that we've now had a few biopsies that have been pre-immunosuppression, and then after the round of treatment with both of them were on mycophenolate, and looking at how and if they have resolved, I think is a kind of an interesting topic. JD, you said you won't be able to talk until later. Is that correct?
Yeah, I just have to jump out real quick just to bring a dog back to get some blood work. But if I have 10 minutes, I should be good. Then I'll be free.
Okay, if you want to do that now, I could actually start with Charlie because that's the OSU case, and then we could at least look at the histology. I don't have the EM back for it, but we could look at the histology for that case if you want to do that now.
Yeah, that sounds great. I'll jump out to bring this patient back, and I'll be back in about 10 minutes or so.
Okay. The case that I'm just going to show some photos for is an OSU renal biopsy that was biopsied, I think, originally. Actually, I have it in. Let's see. Hold on one second. Hopefully, you guys can at least see the submission form now. So it was biopsied in early December. I think it probably the biopsy probably came at the end of November and then finalized in early December. Do you think that's right, Dr. Langston?
Sorry,
2017.
Yeah, so about a year ago.
It was the Charlie was first biopsied on 28 December 17.
Okay. Sorry. Yeah. So we've been, and then you basically had a year of treatment with mycophenolate, had been on telmisartan and amlodipine during that time. And it sounded like the proteinuria had basically almost completely resolved by this past July. Anything else, Dr. Johnson? I can see you kind of chatted.
He's gaining tons of weight. He looks good.
Like good weight or bad weight?
He's getting a little on the portly side. For a renal patient, I'm actually not too unhappy about that.
Is he eating a renal diet with all the extra fat in it?
I believe so. Yes,
A renal diet for a dog with a good appetite will fatten him up.
it really
Okay.
will.
Marianne, sorry you had problems joining. Some other people did have problems joining. I didn't personally have problems, so I wasn't sure, but hopefully now you're able to hear us as well. So we were just quickly reviewing something that we only have light microscopy for, but has had a repeat biopsy. So this is a dog that was biopsied in 2017 in December, was diagnosed with immune complex disease, and it was a membranous pattern in December. And then had been treated with immunosuppression and other therapy, and the proteinuria was resolved by July. Mycophenolate was continued, and so then when they brought the dog back in and they were trying to decide to taper mycophenolate, the owners allowed us to do a a 1 year out renal biopsy. And I've said this multiple times through multiple places where I lecture. You guys are willing to give me a first biopsy, and you want me to look at a second sample from the animal, whether it's a euthanasia sample or a repeat biopsy. I do the repeat evaluation at no charge to you, because right now the dearth of data we have isn't about what type of diseases happen. It's about whether or not our treatments are effective. And so we have to judge that based on clinical effectiveness and then also structural histopathological effectiveness. And so that's why I do these second evaluations at no charge to the owner. And it looks like from Dr. Johnson putting in the chat discussion here saying that his proteinuria and azotemia have completely resolved. His urine concentrating ability is improving, and he's kind of portly now. He's putting on weight, and he's on his renal diet. And so all I have at this stage are light microscopy pictures. Sorry. Oh, yes. I have a vet student in my room who is going to be a pathologist, and so I'm moving stuff around so she can have a place on my office to sit. Otherwise, there's a lot of standing. You got it?
The dog was a 4-year-old dog with nephrotic syndrome when he was diagnosed and biopsied 12, 13 months ago. He was UPC around 10, albumin around 1.5, 1.6, mildly azotemic with creatinine 1.7, and pleural and peritoneal effusions. So it's clinical nephrotic syndrome in all its dimensions, and membranous nephropathy.
And the biopsy cores were pretty good. They were pretty long. However, they didn't have very many glomeruli, so I only had one good glom to look at on histology with all the different stains. And so if you guys can see right now, I'm going to make it a little bit larger so you guys compare the cross section of this glomerulus. I'm not entirely sure why this image on figure 4 is so dark. I can retake it. But we only had one really good glomerulus to look at, and the capillary walls on this glomerulus are still thickened. And if we go to the PAS, which is a good way for us to assess capillary wall thickness, we're going to compare the thickness of the capillary wall to the thickness of a normal tubular basement membrane. Do you guys see the crosshairs as I'm drawing here?
Yes.
Okay. So you guys can see this is a normal tubular basement membrane, and it is thinner than the glomerular capillary wall. So that tells us the capillary wall is too thick, which would be consistent with the diagnosis he originally had. And then we have hypertrophy of the podocytes. It's definitely a podocyte. It's hanging out here in Bowman's space. But even so, we don't really have hypercellularity. So we still have a thickened capillary wall. We know his previous diagnosis was membranous, so that's probably all from the membranous change. Both the trichrome and the Jones show us a little adhesion between the peripheral capillary loop and Bowman's capsule. So we have a small synechia in the single glomerulus. And so, when I was able to go at high mag, oh, I know why it's different colored. It was because I clicked on it. Sorry. I know how to use computers. Okay. Sometimes I worry about my inner dialogue coming out. Okay. If when I'm on the scope and I'm looking at this, and it's not as pixelated because it's a picture, there are tiny little holes within the glomerular capillary wall, which we expect with membranous. So this is all evidence that there are still changes in the glomerular basement membrane. I have not done the immunofluorescence yet, and I have not done the EM yet to see how, if the deposits are still prominent. Those are the last two steps for me to do to say, are we still having new immune deposits, or is this all old residual disease? If I look at it in electron microscopy and all of the previous deposits are slightly electron lucent or have halos around them, then I'll know that they're undergoing reabsorption. I look at them and the EM and I see new deposits on the surface of the capillary loops, and I'm going to know that there's still ongoing new immune complex deposition. I sent the clinical discussion and the clinical follow-up for this dog to our OSU human nephrologist, and he said he would probably, in the case of membranous, treat more on clinical signs. So we already have the established diagnosis of membranous, and he said that because it takes so long for those deposits to go away and reabsorb, that he would be happy to make his decision about tapering more on the proteinuria and not necessarily on whether I see deposits or not on EM. So, because he just expects it to be a long course to get rid of these deposits. So he thinks that tapering the mycophenolate at this point seems like a pretty good option because the proteinuria is normal, or the proteinuria is no longer there. And then obviously tracking and making sure that when you taper the mycophenolate, it doesn't have a recrudescence. But I'll have more information once I get the electron microscopy, which I think should be next week, to figure out how much ongoing deposition there is. Is that your plan?
Yes, it's my plan. I haven't really talked it over with CJ, who's using the case primarily.
Well, but besides the UPC being what it is, 0.3, the dog's gotten, nice serum albumin at 3.4. The creatinine has fallen from 1.7 to 1.3 while the dog's gained weight, which is, maybe partly muscle. And he's got no effusions or anything. I mean, if you can't declare this one, if you will, cured, I don't know when you can.
This brings back to mind, George will know Cooper
Yep.
Menton. Cooper Menton was a dog that presented also, I forgot what breed it was at the moment, but really profound nephrotic syndrome, had a UPC of 40, an albumin that was less than 0.1, and it took that dog ultimately fully recovered to a urine protein creatinine ratio of 0.1, but it took a year before the dog responded, and this was before the days of mycophenolate, or at least before the days we were using mycophenolate. So he really got a variety of immunosuppressive strategies, but it took an entire year for that dog to get to normal, or clinically normal. So,
Are you, as you guys taper the mycophenolate, are you going to keep him on the amlodipine and the telmisartan? Any thought or comments about that?
I guess that I am. I guess that my experience with dogs who respond is limited, sad to say. And I guess that I am a smidge concerned about stopping everything simultaneously. So if I were managing this, I would taper the mycophenolate, and then if the proteinuria is still okay, start tapering the other medications. But CJ's got this case for another 6 months, and so we'll see what she does.
Yeah, it looks like that's kind of what she's discussing here on the chat as well. So I think it's obviously follow up in these cases. We have so few cases that have been rebiopsied. I think probably now we might have about 20, 25 cases that have been rebiopsied or have autopsy specimens following the biopsy. So, I mean, that in and of itself would just be of interest just to know whether or not structural changes actually follow the clinical changes or whether or not they lag. And in human medicine, they're known to lag. So the structural changes are still there, even though the clinical improvement is quite marked. And I'm wondering, JD, are you back yet? Okay.
I'm back. And one question I had for you guys too is, what is the method that you guys would taper mycophenolate? Because we kind of talk about that. I think it's an easier thing to think about when we're tapering pred, but when people say tapering mycophenolate or tapering cyclosporin, exactly what changes are people planning to make to the drug therapy?
Yeah, and can I ask also, was mycophenolate the only immunosuppressive agent?
I think, let's see if I know Caitlin yeah. She says yes.
CJ, didn't we do Dex SP or some short steroid for the first week or two? It was a year ago. I don't really remember. Okay.
If we go back many decades, and I hate old timers that do this, but we used to talk about animals that had membranous pattern disease that got better, and our dear friend Carl Osborne would say, well, yes, the experience is that there are spontaneous remissions. And so how would we address that criticism? I mean, obviously the way to address it is to have more case material, but on one like this, where you have such a dramatic response, the animal was on therapy, how would you address the critics that would say, oh, maybe this is just one that had a spontaneous remission and the underlying immune mechanism went away?
If it comes back after drugs or after ceasing drugs, I would think that then the drugs were effective. We have had a few that I know that when they've gotten a biopsy and they haven't, like, they've literally been proteinuric for a year, a long time before the owner has consented to biopsy. And by the time I'm looking at it, I only have electron-lucent holes in the GBM. And so my comment is that the deposits probably went away on their own, and this has been going on for quite some time. So I do know there are some that have never gotten drugs, and I can see evidence of reabsorbed deposits. So it happens, but I don't know if if giving drugs speeds up or it speeds up the remission. But we do know that within humans like that have relapsing membranous, they'll be fine, and then 5 years down the road they'll develop proteinuria again, and so then they have another bout of antibody or antibody antigen formation. So I think you're going to have to fight against that, saying like, well, this could have been spontaneous remission, but if we take off the mycophenolate and the animal relapses, then we know the mycophenolate was at least effective for this particular patient.
Yeah, exactly. I've had some patients that were proteinuric for extended periods of time off drugs, and then when we started the drugs, the disease went away. So I think there are arguments that the therapy is somehow related to the improvement.
I've had a cat that was nephrotic that I never gave any immunosuppressives to. I treated it with an ACE inhibitor and things, and it went into remission. It was still somewhat proteinuric, but much less so. And actually, I followed that cat till, like, it presented, it was a 4-year-old male or something like that, and it developed more like common or garden CKD at the age of 11 or something like that, and and that cat was never treated with any immunosuppressives.
Question regarding
did anybody give JD an answer about what the tapering mechanism or the doses that you guys go to?
Hey, Thank you.
Okay.
So my thoughts are, unlike steroids where we kind of recognize an immunosuppressive and anti-inflammatory physiologic dose, that I really don't think the same thing can really exist with other drugs. And I think Andrew Mackin's data would suggest that even at a 5 mg per kg dose of cyclosporin twice a day, you're not reliably suppressing T cell function where 10 mg per kg you typically are. So where steroids were tapering in part to go from immunosuppressive anti-inflammatory dosages, as well as allowing the adrenal glands to start functioning, I don't think from a pharmacologic standpoint, taking the dose of mycophenolate or cyclosporin and reducing it by 25% or 50% actually has a lot of scientific background. You know, I think if there's a dose that it takes to suppress T cell function and B cell function, depending on what drug we're talking about, there's probably a dose that it takes. Below that, it's probably ineffective. So I think personally, the way that I taper these other immunosuppressants is by keeping the dose the same, but then changing the dosing schedule. Rather than giving the mycophenolate twice a day, we could go down to once a day, then every other day, almost like a pulse therapy. It just doesn't make pharmacologic sense to me to decrease the dose, because I think we'll probably reach subtherapeutic dosage pretty quickly with that regimen. But I just wanted to see what everybody else was doing and what their thoughts were on that plan.
Well, JD, why wouldn't you undergo the same reduction of efficacy with extending the interval? I mean, with your suggestion, your logic, which I would ascribe to, if you're going to stop, why don't you just stop?
Actually, that's what I end up doing. You know, more often for my GNs, if and when they respond, if I think that they're in remission, I typically just stop them cold turkey and haven't necessarily tapered them. But you know, for other diseases like IMHA and things like that, where I've seen people taper those second agents, I just had that same question of, are we actually doing anything? I feel like if you want to taper, and whether we need to or not is probably a question we don't have data to support. But it's pretty typical in people that they'll treat them and then they'll stop therapy, not necessarily taper them. But I think for these other drugs, to me, it makes more sense if you plan on tapering, that it probably shouldn't be a dose reduction. It should be a frequency of reduction. But that's my junior pharmacology understanding of things. Wasn't sure what.
And the next question is taper over what length of time? You know, 2 weeks, 2 months, 2 years. You know, I would argue that if you do what JD's talking about over a 2-week period, you're just stopping slowly.
Right. Yeah, I'd agree.
Looks like we have more studies to perform.
I can say from patients that we've treated that the ones that we've stopped cold turkey have done fine, but you know, I'm talking off of the handful of my good responders to biopsy proven immune complex GNs that I continue to have follow up on. But that's generally what I've done, is when I think that they're in remission, which most patients aren't based off of second biopsy. It's based off of you know, 6 months to 12 months of immunosuppression, all their values normalizing or stabilizing pretty significantly, and then we basically take that gamble, and the owners know that, because I always prep them to, you know, and offer the repeat biopsy, but it's so uncommon people go for it, that maybe we'll see they relapse and we have to start up again. But
So
I've just stopped.
If we stop Charlie's mycophenolate tomorrow, how long will it take before we would see proteinuria again if he relapses? Is that something that's going to happen within a month, or is it going to take longer to see a recurrence?
Well, sometimes the recurrence in humans is because they have another kind of bout of an inflammatory stimulus. So like they might have been completely all the bad B cells that are making the bad antibody are gone, and then they have another almost situation down the road. But that's not. But that in that situation, that's like a new episode per se.
Yeah.
But I don't know about in dogs.
I think the answer, Kathy, is it depends. It's really a different thing for the previous episode to recrudesce than for it to be in remission and the dog go along and have another episode of membranous, like having a car accident, back in 2013, and and you get the car fixed and you drive it around for a while and you have another accident. That's just poor driving and misfortune. But so the answer, I think, is that proteinuria is likely to reappear within weeks of the beginning of a new episode of immune complex deposition, whether it is so soon after the stopping of the mycophenolate that we would essentially conclude that it's a recrudescence of the previous disease. We were stepping on it, but and had it down, and but took our foot off its neck a bit too soon, or maybe way too soon. Versus, but it could come back in 3 years, and and there would be proteinuria a few weeks at the most after a new round of immune deposits began occurring. We see proteinuria in dogs that have such recently deposited immune complexes that there's essentially just a few of them, and changes in the podocytes and no changes whatsoever in the GBM. You feel like you're standing there almost a day or two after, certainly a week or two at the most, after the complexes first began to deposit.
So I guess we can
I don't have a good answer for you, Kathy, based upon data or anything like that, but my general practice is if I stop the immunosuppression, I usually recheck them again in a month. If it all still looks stable, I check them again monthly for a total of about 3 months after we stop, and then maybe every 3 to 4 months for a couple rechecks, and then if they're still doing well, probably take them down to once or twice a year, just because I feel like we'll probably pick up on a recrudescence of their proteinuria prior to them showing clinical signs. So I try to be a little bit more on top of things, even if they're doing well clinically. But I don't know the timeline of if they're still active, how quick you are to see it. I would expect you would catch it in that 1 month recheck, but again, that's just my hunch rather than data.
The way veterinary medicine works. I guess we can move on. This is a somewhat similar kind of repeat biopsy situation. This one's been going on since so it's been for 2 years that we have follow-up data. Do you just want to give a brief synopsis about when things went bad and then when they started to improve, JD?
So Winston is a Cavachon who's probably had proteinuria for closer to a good 3 years or so, was managed with a neighboring internist. Once he, with just standard therapy, once he started to become hypoalbuminemic, he was sent to me for additional management. We biopsied him, and that was biopsy number 1. And I'm not sure, Rachel, if you were going to show any previous.
Let me just show you a couple quick pictures to compare to the one we looked for Charlie, because I think this is a good pathology review. So with Charlie, we just saw thickened walls, but the glomeruli themselves were not hypercellular, whereas Winston has kind of the 2 hits, right? So there are too many blue nuclei in here, and not only are they present in mesangial zones, but they're also kind of obscuring where capillary lumen should have been. So this should have been an open capillary lumen. And you can look on the PAS. Here is what remains of that capillary lumen. and you have 3 nuclei in here, and that's way too many. So we have mesangial hypercellularity, and we have endocapillary hypercellularity, and then we also already start to have some adhesions between the tufts and Bowman's capsule, and some loss of capillary lumens, which is a lesion we call sclerosis. So that there was already a lot of kind of chronic disease in Winston. And if we go to his electron microscopy, so here's a whole glomerulus that's pretty much completely scarred. So if you can think about it, there's no lumen here, which means that, and there's no blood that's going to be circulating through the segment of the glomerulus. So all of this is just going to be decreased amount of surface area for filtration. And you can also see on the trichrome stain that we already have some inflammation in the interstitium, and we have expansion by fibroblasts. So we have a little bit of tubulointerstitial scarring as well. And then his electron microscopy was helpful because we can see the deposits, and there's not, there is some mild remodeling of the glomerular basement membrane, but as we go through this case, we're going to see this glomerular basement membrane being much more remodeled. And so in this particular capillary loop, we at least have areas where red cells could go through. So we have some lumen, but we have multifocal deposits along the capillary wall. And in comparison, Charlie is going to have his deposits near the podocyte, and Winston, the case we're looking at now, has his deposits near the endothelial cells. And then we already have some kind of thickened walls here, which is because mesangial cells at the base of the capillary start to send out cytoplasmic processes. I make up a story that they're trying to stabilize the glomerular basement membrane. Maybe they're trying to eat some of the deposits. I don't know what they're doing, but they basically make this wall thicker. Podocytes aren't happy. They have lots of microvillus transformation, and they have effacement of the podocyte foot processes. You go to the IS, you'll see it's positive. I can get there. Oh, that's a capillary, sorry. The immunofluorescence, our lambda is our better, our best, most robust stain, our lambda light chain. And we even have some kind of plasma getting pushed into the afferent arteriole. C3 was there, but it wasn't super strong. So that was the first biopsy. And so then you started doing, how did you treat JD?
Winston, we treated with mycophenolate. I don't think we treated him with steroids at all. I think we just treated him with mycophenolate since he wasn't azotemic. He was otherwise fairly stable, and he did well. He recovered. He clinically was doing terrific at home. I think between the first and second biopsy, it was probably maybe about a year or so that he was on mycophenolate, tolerated it very well, no complications with it. But similarly, we had seen that his values had improved. So I think it was maybe October 2017 that we ended up rebiopsying him to see if there were any active lesions that necessitated ongoing immunosuppression. So that led us to biopsy number 2. And clinically, he'd been doing well, and his values had improved at this time.
So then his second, his second biopsy, you guys biopsied it in October, and we got it the first thing in November. Why is it not opening? Hold on one second. All right. So this is our repeat biopsy, and now we have kind of evidence of more segmental and global glomerulosclerosis. So if we look back at his first biopsy, one second, hold on, let me go up. His first biopsy had 57 glomeruli, and about 20% were globally sclerotic. So there was already, and we'd had 1.5 years of proteinuria, so that makes sense. And his second biopsy had 13 glomeruli, and so about 30% 30% or maybe 30% were globally sclerotic in the second biopsy. And the lesions are very, very similar with, again, endocapillary and mesangial hypercellularity, a lot of synechia, and a lot of glomerular basement membrane remodeling. And the electron microscopy now shows a lot more GBM remodeling secondary to the deposits. And these deposits were kind of in multiple locations. So remember, the first biopsy had them a lot where there were subendothelial. And these now are, some of them are kind of going into the subepithelial zone. We still have subendothelial in some places. Like in this particular capillary loop, if I zoom in, these deposits are all over the place. They're almost like transmural. So like the whole wall of the GBM has a deposit in it. And you have a very thickened glomerular basement membrane and glomerular capillary wall. So the deposits are kind of all over the place at this level. Here's some more that are still subendothelial, so newer deposits in the subendothelial zone. And again, these kind of newer deposits and slightly older deposits as well as they were getting further out. So, and I think the IF was still pretty consistent. One second, let me see the IF. So the lambda, again, and this is a pretty sclerotic glomerulus, it's a little bit hard to see, but all the DIT dots are deposits. And then the glowing stuff is probably plasma, but the DIT dots are the deposits. And we actually have a little bit more prominent C3 staining later than we had in the first biopsy. And so that's in 2017, end of October, beginning of November. And then we got a third biopsy, which was most recently done in December, right, JD?
Same thing, based off of the second biopsy, we continued his mycophenolate since we had clinical improvement. We just hadn't seen the lesions improve on biopsy. So we continued the mycophenolate, rechecked him, his values, he's still doing very well. His blood pressure is controlled. I think his UPC is negligible essentially at this point. So we did biopsy number 3 to try to, again, determine if we're at a stage that we can stop his immunosuppression, or if there were ongoing evidence of immune complex deposition, do we need to consider switching to something else? Do we need to try something different than mycophenolate? Even though there's a clinical response to it, do we need to try a different drug? So that was biopsy number 3.
What was happening to his creatinine, JD? Was that stable?
Creatinine's 1.5 at the time of the last biopsy.
Yeah,
and it had been 1.5 at the previous one as well.
Yeah.
Okay.
And I think 1.5 is not appropriate for him, being a little cavachon, but it's been stable. So I think he likely has some decreased GFR, which makes sense looking at his nephrons here, but it hasn't progressed.
And then also, I just want to do a plug. If you guys are, like I said, we will reevaluate we'll evaluate second samples at no charge. Obviously, it's kind of a lot of a big ask to tell the owner I want to biopsy your dog again, even though he thinks clinically better. So often, we also encourage if you guys submit SDS page samples, and we can follow the SDS page. Dr. Hokamp will be able to do those. I think depending on the case, she'll either do it completely at no charge, because we want to track and see, can we use this as a marker for activity of disease? And she did have some high bands still, even in the high bands on the gel. And let's see, we had a couple high molecular weight bands as well. So we do have evidence that there's some large molecular weight proteins that are coming through the glomerular filtration barrier. So that might be another way for you guys to monitor disease.
Well, the other interesting thing you had on that was the cylinduria, both hyaline and granular casts on here.
On the urine sediment analysis. Mm-hmm. And I know a lot of you guys don't like doing the spins and stuff like that. And Dr. Hokamp has changed her her workflow is that if you guys just send us the urine, then we will spin it once it gets into the lab, and we've still seen pretty good, actually really good samples being able to be processed that way instead of having to have your technicians do the urine, do the spins before you guys send it to us. One more plug for getting those samples sent to us. I'm looking at time, and I was going to pull up these slides on the microscope, but I think it's just going to be easier to look at the pictures that we've already taken, so I'm not going back and forth between slides. So I think it's funny, like I started with the diagnosis of immune complex mediated membranous proliferative, and then later, maybe about 10 months later, we go to chronic immune complex GN in a kind of a membranous proliferative pattern. And then this last December, I just even called it sclerosing membranous proliferative GN. The mixed part, the reason I use that term is because that means on electron microscopy, I'm seeing deposits in subendothelial locations, in mesangial locations, and subepi. So it kind of has deposits all over the place. In this particular sample, we had 9 glomeruli, and all of them had some degree of segmental sclerosis. We didn't have any glomeruli that were completely normal. And so if we look at these, this is kind of typical. We saw where you'd have some, this area here is doing work, and that area here is doing some work, although it has thickened capillary loops. And these guys are basically non-functional because they're completely effaced and adhered to Bowman's capsule. And then this one is almost entirely sclerotic, but we have a few open capillary loops that have a few red cells. And then the silver stain shows us a lot of remodeling, which is going to be present on the electron microscopy as well. It highlights that synechia or that adhesion fairly well between the glomerular top and Bowman's capsule. This kind of ends up being almost the entire mesangium is expanded because there's way too many cells here, and there's a lot more matrix / maybe even deposits in the mesangium. So we have a little bit of kind of a mesangial abnormality or mesangiolitis in some of the glomeruli. And then I did a little bit of a low mag to highlight the fact that we have striped pattern of scarring. So that is sometimes what we'll see either in humans. It's usually suggestive of some type of vascular insult, so maybe some type of hypertensive injury. And I worried about that for this dog. I also worried about that because there's a little bit of hyaline within, or actually a large amount of hyaline within the afferent arteriole or the arteriolar profile. But so I texted JD as soon as I got this, and I said, "Oh, this looks like this has a lot of hypertension." But the dog's blood pressure has been pretty good, right, JD?
It was 110 when we last checked it.
Yeah. So to me, this is tissue. Like if this were a human, I would worry about. Well, if this were a human, I would worry about diabetes, number one, because that's what happens in diabetes. Obviously, that's not what we see in dogs. But I would worry about hypertensive damage to the afferent / efferent arterioles. And then that striped pattern gives me another piece of evidence that this dog has hypertensive injury to its kidney. But whether or not we're just not, I don't know, it's maybe the lesions that we see in humans are not really cross-applicable to the lesions that we're going to see in dogs. But
another thing to keep in mind is that systemic hypertension and intrarenal hypertension and glomerular capillary hypertension are not necessarily all, linearly related to one another. Maybe pressure regulation within renal vasculature is disturbed and poorly managed, while systemic blood pressure is better managed. So.
And then getting to the EM, this is, and I do want to, so the EM for this one is actually now, the reason these pictures are so gorgeous is all of our EM is being processed by the med school. So they are much better pictures than we had for biopsy number 2. But again, you can see that the deposits are here. You have encircling by glomerular-based memory material. And then when I mentioned about how deposits can undergo resolution, this is what it looks like. So you get a little bit of a moth-eaten appearance to the deposit. This deposit's completely gone. He got taken out. He's been reabsorbed, I guess. We don't really know what happens. We just know they go away. So this is that moth-eaten appearance that we know these deposits are technically going away. They just haven't gone away yet. And we have new deposits that look a little bit darker that are still subendothelial, as well as these older reabsorbing or reabsorbed older deposits. So that's a perfect halo that we're seeing around some of these deposits as well. So he's still making complexes and he's still laying some of them down, and he's going to have a lot of scarring. I'm not surprised that his UPC I don't think his UPC will ever go to normal, because he's going to always have that glomerulosclerosis that was probably there even since the very beginning. And I don't know if once you taper, whether or not you're going to get new deposits forming, or if it's going to get worse. Sorry.
Well, yeah, that's the question. Based upon this, I guess my inclination is I'm glad that he's doing well, but there's still new complexes that are being deposited despite the mycophenolate. Maybe they'd be a whole lot worse without the mycophenolate. We don't know. But I guess I'd lean towards considering a different type of drug for him, maybe considering cyclophosphamide. I know that the human nephrologist had mentioned a steroid trial too, and oddly enough, it's probably the thing I have the least experience and comfort with the GN patients, is seeing their response to steroids, since we tend to avoid them. But I guess I'm leaning towards trying probably cyclophosphamide, but wanted to kind of pull the audience and see what everybody thought and how you guys might manage it at this point too.
I don't know how I'd manage it, JD, but there are sort of two aspects to what we're looking at. One is the chronic change, the residue of his disease that is still evident is more prominent than in the middle biopsy. And there are new complex deposits that are evident, but there's not as many of them as there were before. So, I mean, you have, he's lived for quite a while with his disease, and he's doing well. And actually, if you look at the morphology of most of his glomerular capillary walls, you got to be pretty happy that his UPC is not more than 2.
I'm thrilled that he's not, or his creatinine's not 6 at this point either, too.
Right. Okay. So, I mean, you've placed a lot. And the mycophenolate is, I think, in a sense of active immune complex deposition, is controlling his disease better now than it was in the middle biopsy. He's lived with his disease and had more scar and remodeling of GBM and all that, and certainly more dissolution of deposits than was present before. So, a part of this is just the after effects of having been sick with what he's had for 2 years or 3.5 or however long. And I agree that there's evidence that his immune complex formation / deposition and response to it. Do we have there's still complement in active? Is there not?
Yeah, I think it. Let me go. And Dr. Johnson wanted to know if he was on RAS inhibition as well. JD, is he still on that? Yeah, it's like segmental. I mean, yeah. It's
so there's a little. So the idea is that his disease is still active. So you either trust mycophenolate and keep going, or you switch drugs. And I have no problem with switching drugs. And cyclosporin. Excuse me, I misspoke. Is commonly used in people for this, and it might very well do a better job. But no, nobody's got data that says it will.
Has there been a pattern shift of his immune deposits from capillary to mesangium? And maybe, he still has the same degree of immune activity. It's just relocating to his mesangial region rather than his capillary.
The new ones are subendothelial, which has always been the prominent site of their deposition. Is that not correct?
Rachel called it mixed now,
well, that means mixed inside and outside.
Yeah, but and mesangial.
Yeah.
And then it seemed like there was a lot of mesangial activity on this last biopsy. I mean, is that something to consider as well, that maybe the disease is ongoing as it always has been, but the deposits just get in a different location?
It's hard to say because obviously we're looking at each time we're looking at a different glomerulus. I think there was always mesangial hypercellularity, and this probably up here is a mesangial deposit on biopsy number 1. So I do think that if you compare the glomerular-based membrane from year 2016 and how that's a pretty normal GBM for a dog. In a lot of the cat loops, it was a normal GBM, and then you go to 2007, 2000, whatever, 18, whatever. This past December, it's about 5 times as thick in the narrowest regions, and in the thicker regions, it's about 10 times as thick. So we definitely are synthesizing a lot more GBM matrix to try to wall off the deposit. I think these are the kind of cases that we need to follow, and I'm glad we're having as much information from the owner that they're able to do this. But I don't know what to tell you other than if you try a new drug and you're going to monitor, so we're going to get the information about whether or not this is successful or not. Did you say, Dr. Foster, whether or not this dog is also on RAS inhibition? Dr. Johnson had a question. JD might have had to step away.
Hi, sorry. Dr. Foster says yes, he is on RAS inhibition. He's just had to step away for a phone call.
That's what I figured. Okay. If there's any other suggestions, or if there's a good way to start collecting all this data and saving it for future publication, let me know. I could do a search really quickly and probably find all the dogs that we have repeat samples for. We do track it in our database to say this is biopsy number 1, this is second biopsy, this is third biopsy, this is autopsy. So we do have a way to track all these like repeat cases in our database if we wanted to try to figure out how it would progress.
Rachel, one last question. I have one last question. So what's happening with these recordings? Like our fellows weren't able to attend this morning, but I'd surely like them, and I'm sure there are others, that this was a very excellent presentation. Is there a spot where these recordings are going, or am I supposed to be putting them somewhere?
When I've done them, let me look. Hold on 1 second. Let me go back. I have them in, and it actually might be the other one. I do have a set of rounds or a folder on one of the shared boxes, whether it's Pledox or Dropbox, I'm not sure. But I think it's here, and I have, sorry. So I do this nephropath presentations, and anybody who wants access, I think a lot of people on this group already have access to this. And I have some of those all sent, and I say what we talked about and which cases we discussed. So I have a lot of this already kind of accumulated. If you guys ever want access to these rounds and you want access to the recordings, either most of you guys already have access, or you can ask me for access and I can invite you.
Thank you.
Yeah, we always are a little bit obviously gun shy with when they have no platelets and they want to go shove a big catheter into their neck. But surprisingly, like we've had a couple dogs that we treated with for ITP with, yeah, exactly. And those dogs actually didn't have bleeding complications where we were worried about it. So I'd still be concerned that.
I'm not sure if that was a phone call.
It sounded more like his phone call than directed at us, so I muted him.
Yes, it was.
Okay. Okay. So if you guys have any other things, we'll reconvene next month. I know we did this on the 5th Thursday. It was just because I couldn't possibly do it on the 4th Thursday. But we'll send out invites again, and we'll maybe by then we'll have information. We will definitely by then have information about what Charlie's electron microscopy looks like. And hopefully, we actually have had a recent spate of cat kidney biopsies, so I think it would be kind of cool to start looking at some cat kidneys biopsies and better recommendations for evaluation of those. So maybe I'll put even a call out when I ask for cases, especially if it's a cat case, it would be cool to look at that. But otherwise, I think it's coming up to 1. So if there's no other questions or comments, we'll probably end here.
Thanks, Rachel.
Okay, thanks. Have a good month.
Thank
Bye-bye.
you.